Thank you, Peter, for the nice introduction, and welcome everyone to today's webinar. As you can tell from the title, I'm going to be really talking about three things: teenagers, co-occurring disorders or coexisting disorders, and developmental perspectives on the issue of coexisting disorders. The first slide also reminds us there are a lot of disorders that tend to coexist when a teenager reaches clinical symptomatology. So if you're working with teenagers that have a substance use disorder, often you see other mental behavioral disorders. When you are treating a teenager who might have a primary problem of ADHD or some other mental behavioral disorder, often drug use or even a clinical level substance use disorder is present. So let me start with a little introductory comments, and then I'll launch into the main body of the talk. For those interested in more resources, I found 4 of them that I particularly like. One of them is the free one, the first one there, tips number 32. You may know about that series from SAMHSA. 32 is a good overview of the treatment field. It's a bit outdated, but I think you will still find a lot of it very helpful. As you may know, you can download those tips or write to SAMHSA and they can send you a hard copy. Then I have listed 3 publications. All of them are edited books, but there's a $ next to all of them because they are cost items, but you can see the websites there and you could do some window shopping. There is a recent one, that first one with a $, Clinical Manual, is from 2011. So the core of my talk is going to be organized around this slide: 6 habits of highly effective professionals. That is, professionals when you're working with a teenager that has a drug abuse and a coexisting disorder. Most teenagers with a drug problem also have a coexisting or co-occurring disorder. So these 6 habits come by way of the research world, my view from clinical perspectives, my input in it, or the knowledge base that I've gained when I've worked with my staff, both in clinical and research settings. And so they run the gamut. I'm going to tackle developmental issues, assessment, treatment, and also make sure we talk about the family as well. So let's start with number 1. It's an important principle for those working in a clinical setting with teenagers, that you are knowledgeable and have a good understanding of important developmental principles and characteristics of being a teenager. So there's several points within this theme I want to highlight. First one is the importance of understanding that in many ways being a typical teenager can bring to bear a lot of characteristics and behaviors and attitudes that might look like they are clinical problems, but they aren't necessarily. The high emotionality, the roller coaster ride in some ways that teenagers play out those years can look like somebody is suffering from a bona fide clinical disorder, but they might not be. They might just be displaying that wonderful life of being a teenager. So let's put that idea under the microscope for a bit. I have on this slide the 9 criteria from the most recent DSM, DSM-5, for borderline personality disorder. A disorder that has an adolescent onset, as you may know, for those that know this disorder. So here are the 9 from the manual, and I read through these 9 and said, gee, a lot of them really look like symptoms and characteristics that you might find in a typical teenager. So with this slide, I've highlighted in red the 7 out of the 9 that I thought were particularly interesting in terms of overlapping with what might be viewed as normal adolescence. I won't go through all of these 7 individually, but if you read them, you realize, yeah, okay, I can see teenagers showing this, or I know parents have complained about this in their teenager, or for those that have raised them, you might have seen it in your own home. Identity disturbance, impulsivity, pattern of instability pertaining to relationships, etc. But a bona fide diagnosis of borderline would be able to separate out, well, what are these features here that might look like they're normal versus clinical. And so it often has to do with intensity, the underlying functional value of the characteristic, etc. Those are the things that distinguish a clinical level problem. So someone doing a good diagnostic workup should be able to make the difference or understand the difference. But you can see that it's important that we keep that in mind and that we always have a sharp assessment process in place and appreciate the importance of a good diagnostic workup. The second point I want to make in this developmental topic is revolving around that new science, emerging science, that the adolescent brain is continuing to develop during the adolescent years in important ways. And in fact, the maturation process isn't complete until about age 25. Now, this has a lot of implications for how we understand teenage behavior. So it's not just that the brain is developing during these years, but it has to do with this interesting pattern, this differential maturation that occurs across regions of the brain. With this slide, hopefully you can see how parts of the brain are getting blue a little faster during this age span of 5 to 20 than other parts. It's almost an enveloping type pattern here. So some regions of the brain are maturing or having all of their neurological brain processes complete sooner in the teen years, while other regions it's taking a little longer. Now, the one major region for which this maturation process occurs near the end of adolescence is the prefrontal cortex, or the so-called judgment region of the brain. This is the part of the brain where you exert a lot of your heavy lifting of decision making, where you resist impulses, where you delay gratification, where you have to consider short and long-term consequences, where you balance emotionality and context and influences from peers with perhaps your value system or rules and laws or a goal you have, etc., etc. It's kind of called the seat of sober second thought, where you engage in your sober second thought. That part of the brain tends to develop later in adolescence, thus suggesting that parts of the brain that are more related to emotion and motivation might have a stronger influence on teenage decision making as opposed to sober judgment. Developmental psychologists have looked at this science and tried to come up with some principles of how we understand teenage behavior based on this neurological development. So here's a list of 8 of them. And they all sort of reflect where scientists think how brain development might lead to certain tendencies or biases in behavior and decision making in teenagers during the teen years. If you look at the 8, you will see perhaps yourself in the list, which makes sense because adolescence isn't a time where necessarily something unique emerges, but it's a time where you might see certain tendencies or biases or preferences dominate. So, for example, number 4 on the list. The suggestion is that the way the brain develops that might lead to a very high preference for novelty. Well, we all like novelty, but during the teen years, the notion is that seeking novelty might dominate over other values or other motivations, more so than an adult who might do a better job of balancing a lot of things in the face of novelty. Now, also this list might be considered.
There, with the update of the brain pattern there was a little, you might need to hit refresh on your browser just so you can be able to see the most recent slide that's happening right now.
Oh,
so if you just hit refresh. For those online, just hit refresh.
So they're able to see this slide.
If you can go back to where you were talking about the one after this one.
Yep. Very good. Okay. Excellent. This list here is, again, as I was noting, some of the sound bites that come from developmental psychologists regarding how we might interpret this brain maturation when we think of behavior and attitudes. When you read the list, you might also look and see, hey, this could be a list that suggests risk factor towards a behavior that can be a problem in the teen years, and that's drug involvement. Particularly items 2 through 8. If you think of each of them, you could probably come to some impression that each of them could contribute to a teenager's curiosity to use drugs as well as continuing to use even in the face of negative consequences. And this is why this brain science has been looked at in light of the high-risk period of the teen years when we see often an emergence, or at least a higher prevalence rate, of a substance use disorder during youth as opposed to later in life. This is one database that reflects it. It comes from a national study, and you can see the past year rate of DSM-4 alcohol dependence is at the highest in the youngest years, and it decreases throughout the older years. So the youth period might be a very high risk era in one's life for getting in trouble with drugs, and perhaps brain development contributes to it. The third point I want to make related to our developmental picture here is that co-occurring disorders are common among youngsters that have clinical problems. This is just one slide here that shows how to look at it. There's a lot of different ways if we want to talk about how frequent coexisting disorders are among teenagers at a clinical level. And this slide here reflects my effort to try to summarize data where the data started with youngsters that had a substance use disorder and then looked at what were the other coexisting disorders among them. And the top 4 are listed there: conduct disorder, ADHD, depression, and anxiety. You can see the rates are ranging, but they also are provocatively high. The ones below, bipolar, PTSD, borderline, learning, and eating disorders, I don't have numbers there because the data are not strong yet as to what would be accurate prevalence rates. Might be because they're at relatively low rates and you need large studies to get a good read on it. But they are disorders that also do show up among youngsters that have a substance abuse problem. A couple sidebar topics. The first one is, so why is there coexisting disorders? Why, with a teenager that has a drug problem, do we often see the co-occurrence of other mental behavioral disorders? In the literature, researchers have talked about 3 different models. One that's called the dysregulation model. Coming up in a second, I'll elaborate. Another one, self-medication, the notion that drug use is actually self-medication underlying and pre-existing behavioral problem. And then the third, vulnerability to stress. There might be an overall stress in one's environment. This can lead to a lot of behavioral havoc, including experimenting with drugs and the emergence of other problems. The dysregulation model seems to have a strong support in the research literature. So I'm showing you this slide. There is support for all 3 models. This one strikes me, though, as a quite strong one because there's a lot of longitudinal studies now that have tried to track the early emergence of risk factors and then looked at what might portend early substance use and how that might also play out with eventually impacting a pre-existing condition. So the so-called dysregulation pathway for drug use shows up in the following way in the literature, where in the childhood years there's an emergence of what's called early regulation problems or problems with self-control. And that then is believed to contribute to a risk towards developing then a little bit later in childhood or early adolescence to adolescent-based disorders, ADHD and or conduct disorder. And then it's believed that those 2 disorders can contribute to curiosity and experimentation with drug use for various biological and cultural and sociological reasons. And then when somebody gets a drug problem, that unfortunately can exacerbate the conduct disorder, and that can lead someone toward a more delinquent pathway. So the conduct disorder gets potentiated by that early drug use. A database that is part of this longitudinal story comes from Australia. This is a New Zealand study, the Moffat group. They showed how measures of self-control in early childhood was related to adulthood risk for substance use dependence. Two lines here. One is the substance use dependence index score based on self-report, and the other one is substance dependence scores based on an informant of the index individuals. And you can see the relationship is quite strong. Those that had the best childhood self-control had, or considered the high at the far right, they had the lowest probability of an adult problem with substance use. Those that had the lowest childhood self-control ratings, they had the highest rate or probability of an adult problem. Childhood self-control was measured more than once during pre-adolescent years. Pretty strong data. Of course, it's not fate. Self-control behaviors and attitudes can be shaped by one's environment and many other factors, whether it's formal intervention or whether it's part of one's growing up experience. Then there's another way to look at this topic. Does early substance use lead to the development of a mental illness? That's also part of our coexisting story, isn't it? So what do we know about that potential hypothesis? Here's correlational data. Provocative, but we have to be careful because it's correlational. This shows a relationship of early onset marijuana use and the probability of having an adult mental illness. So the way you read this chart, go to the far left bar, the one that has less than age 12 below it, and that has 21 at the top of the bar. So from this national database, this says that among those in that data set that said they started using marijuana age 12 or younger, 21% of them had a past year, or reporting a past year as an adult, serious mental illness. So serious mental illness as an adult, these would be in the affective disorder categories, psychosis, schizophrenia, etc. Anyways, you can see how the rate of an adult problem decreases as a function of waiting later in your youth years to use marijuana. Suggestive, not causal, because it's correlational and there could be all kinds of third factors involved here. But provocative in the wrong direction. This data set's a little less correlational. It has some more interesting features to it that also help us with our question of how much does drug use contribute to a mental illness. This is a meta-analysis that had an opportunity to look at a lot of studies that looked at age of onset of mental illness as a function of whether you used a drug or not, or a substance or not. And there were three major groups studied or analyzed. The first one to the left there, alcohol. The number above it is virtually zero. And that means that when a group of youngsters that had a serious mental illness that had used alcohol when growing up were compared to a group that had a serious mental illness that didn't use alcohol, there was no difference in the age of onset of that serious mental illness. So alcohol didn't have an impact on creating a sooner or earlier onset of the disorder. But the middle bar is pretty provocative, the cannabis bar, 2.7 on the top of that bar. That means that, on average, the youngsters that used cannabis in their teen years had the onset of their mental disorder occur 2.7 years sooner than the group, the control group, that is the serious mental illness or psychosis group that didn't use marijuana in the youth years. That is statistically significant, as well as the group to the right, which is any drug, so they lumped all substances and still found an earlier onset pattern. Earlier onset means a worse course, probably means less receptivity to treatment, and may also mean you have more severe symptoms. So all bodes poorly from this data set. So these are kinds of things that are getting studied now with longitudinal investigations. Okay, I move on to habit number 2. This is a principle, hopefully you can appreciate, that treatment can work. And so what does the data tell us with the treatment literature for coexisting disorders? Well, one thing we know, treatment approaches do run the gamut. I've listed here 6 that are relatively common, at least studied in the literature, and appear to be commonly applied if one looks at the clinical application literature. And it is tough to know because it's the science behind what is practices, the common practices in the field is less rigorous than what is studied in the lab. So familiar names on the list: CBT, motivational enhancement therapy, which usually is going to include motivational interviewing, perhaps some other features. There's various family therapies, dialectic behavior therapy, 12-step, and pharmacotherapy. So what do we know about outcomes? I tried to summarize some basic principles based on some recent publications. So good news, when people have looked at treatment and compared it to absence of treatment or a control condition or a waiting list, treatment cases do show better outcomes. That's an important finding. It would be very discouraging if we weren't getting at least that. And then when people have looked at specific types of treatment approaches, it's been difficult to identify any individual treatment approach that is superior. But if you read the literature surveys and you read the meta-analyses and you look at the literature as a whole, I think you could come to some conclusion or basis for saying, well, family-based approaches tend to show better results, as well as approaches that use either CBT with or without motivational enhancement. Also, for disorders for which medication looks to be important, there have been some comparison studies with medication alone versus medication with a psychosocial-based treatment. It looks like the combination approaches are superior. What's related to outcome when you look beyond just treatment approaches? A couple things strike me as relevant. One is for youngsters that show improvement in coping skills and have good social support around them, whether it's in the home or with their peers or both, those individuals seem to show more favorable outcome. For the youngsters that are receiving treatment for substance use disorders, a couple things have emerged in literature. One of them is the more participation in an aftercare program, particularly a common one is the self-help approach. That appears to be favorably associated with outcome. And also another feature, perhaps not a news bulletin, the youngsters with a drug problem that are also getting help for their coexisting behavioral problem show better outcomes. An example of that last principle comes from a study from Kaiser Permanente group, and they showed that there was more abstinence or more favorable outcome in the youngsters that got both drug treatment and psychiatric treatment. Those are the yellow bars. So you can see to some degree about 10% increment in abstinence by virtue of those that got help for their coexisting problems in addition to the drug problem. Let me focus, though, on 2 of the approaches. So one of them I want to highlight a bit is the 12-step approach. It's extremely common. It's probably the case, by best estimates of the applied literature, that roughly 2/3 of treatment programs in America use 12-step, either as the primary or embedded within a multimodal approach. So it is a common strategy, still applied to teenagers. What's the literature on it? Well, Sussman did one study where he made an effort to review the existing empirical literature. He found 19 studies that met his standards for sufficient rigor that had employed either the AA or the NA model within a formal adolescent treatment program. Now, many of the studies did not have random assignment. Some of them did not have strong control groups. So his statement that there's strong support, that AA or NA-based treatment is superior to no treatment, you have to keep in mind that these studies were not always of optimal rigor. But when there's been efforts to look at the efficacy of this approach, we get some reasonably favorable findings. But what can be challenging for the teenager with this approach? I've got 4 things listed here, and these are things that I think are important to address if you're going to use this approach with teenagers so that these don't become significant barriers. The lifelong disease can be problematic for a teenager who isn't thinking about that far in their life. And I think the data suggests we don't know for sure if adolescent drug problems is really a harbinger of a lifelong disease. Having a teenager think about committing to lifelong changes also can be problematic. I think some of the developmentally adjusted programs work with the notion of getting them to think about the kind of changes they need to make while they're a teenager and open up the possibility of revisiting those changes when they hit adulthood. For teenagers that are not very socially inclined, this approach might be problematic since there's a heavy emphasis on socializing, sharing, verbal skills. And because 12-step programs encourage the utilization of self-help groups as part of aftercare or continuing care, many communities do not have very teen-friendly self-help groups. Some communities don't have self-help groups at all. So it's a problematic barrier. We have a discussion in my research lab about revising the 12-step program. This slide is really my fantasy slide. There is no 12-step program of self-regulation, but we talk about this as perhaps in the future. Another way to look at 12 steps is not just the standard 12, but also to help teenagers with what we consider perhaps a skill they often need a lot of help with, and that is self-regulation. What part of the brain does a lot of heavy lifting for self-regulation skills? The prefrontal cortex, part of the brain that's not developing and maturing as fast. So perhaps in the future we'll see more focus on that. And then I just want to focus on pharmacotherapy for just a bit. That's starting to emerge as part of the treatment toolbox in the applied arenas. There's, in some ways, we could look at medications within 2 categories. There is a group of medications for treating drug addiction. These vary in how their action works. Some of them are drug substitutions. Some of them address the reinforcing or craving properties of drugs, and some provide an aversive reaction if one were to take the substance while taking the medication. These types of drugs are not commonly used with teenagers, but I'm seeing a greater interest in popularity of their use. We might see more of this being not only studied but used in standard treatment programs. Perhaps more common is using medications for mental and behavioral disorders. So I've listed 5 categories up here, some typical medication groups and types of meds for these basic behavioral disorders. By and large, these are the same meds that are used to treat the adult version. So there isn't yet a large emerging literature that suggests which medications are best for an adolescent version of the disorders versus an adult version. But these are the kinds of topics that are getting studied, and we might see some adolescent principles emerge. It's worth talking about medication for ADHD because it intersects with our interest in ADHD and drug abuse. So one important question to ask: does the psychostimulant medication to treat ADHD pose a risk for that youngster to develop a drug abuse problem downstream as they hit adolescence or young adulthood? Giving a drug that has addictive potential prime the pump and create additional risk for such individuals. So there's been a lot of focus in the literature on this, and most studies indicate no additional risk. In fact, some studies even reveal that you reduce the risk in that ADHD person for future drug use if they were well managed with their ADHD medication. It is a controversial topic, still getting plenty of attention by researchers and clinicians. But the weight of the evidence suggests that the way ADHD medication is managed and delivered helps treat the disorder of ADHD, but does not contribute to some kind of neurological pathway or psychological risk towards drug abuse. Then another sidebar, just a moment to talk about the challenges of adolescent recovery from any mental or behavioral disorder, whether it's drug use, ADHD, etc. Because returning to one's familiar and pre-treatment environment can also mean they're getting exposed to the same risk factors. One can see that teenagers can face some challenges as they go back to their home and their school. These might be environments that pose a lot of risk towards those symptoms and surely could contribute to relapse. Sometimes adults have luxuries, and we can alter our post-treatment, our aftercare environment by changing it so that we don't return to exposure to those risk factors. One thing that's being done in the substance treatment field is the idea of having recovery high schools or recovery colleges. That's a small trend in the United States, but it's a growing one. We're seeing a lot more colleges pick up on this idea, and in many states, including Minnesota, these high schools are emerging as well. It's a nice environmental feature for a youngster that is going to deal with a lot of triggers for drug use, and they don't want those triggers to lead to relapse. And a high school, as unfortunately, can be a source of such triggers. But having a recovery school or a school with a recovery component seems to pose a logical way to mitigate the impact of those potential triggers. Okay, number 3, a principle of personalizing treatment can optimize the effectiveness of that treatment. And one way to personalize it is to see if that treatment is teen-friendly. Having teen-friendly features in your treatment approach. And I'm going to focus on 2 approaches that I think inherently are developmentally appropriate for adolescents. And that is the cognitive behavioral therapy approach and a strong or significant component of motivational enhancement, which I'll focus on as motivational interviewing. So why do I like CBT for teenagers? I think it's not just teen-friendly, but it's teen-brain-friendly because the features of it, I think, speak to the teenager's interest in being in the present tense, dealing with practical problems, helping build realistic skills with the teenager, and focusing on goals that are also practical and important and realistic to him or her. Some of those goals are short-term. Some of them might not be the highest priority of a clinician, but a good application of CBT means you adjust it and you make sure that you're going to focus on goals that are of interest to the teenager to keep them engaged. And you can surely work in even more profound goals as the teenager gets more comfortable with the clinician and more comfortable with the behavior change process. And I like motivational interviewing because I think it's a interaction style, a counseling style that doesn't put the teenager on the defensive. It doesn't make the teenager feel like it's an adult that's imposing his or her standards on me. It's an approach that gives some empowerment to the youngster to help shape the direction of the therapy process. I think all of these things are not only adult-friendly, but are very adolescent-friendly. So just to reflect a little bit more about the value of CBT and motivational interviewing. I think it can help improve motivation. And it's important to improve motivation so you can get clients that are out of pre-contemplation and get them into the more favorable stages of contemplation, preparation, or action. As you know, the theory of stages of change suggests that we want to get our client out of a I don't want to change, I don't want to self-reflect mentality, which would be pre-contemplation, and move them into an attitude where they see the value of change and they want to take action and make changes in their life. And motivational interviewing has some key principles. These are the 5 common ones. I encourage people to read about this interviewing style. Practice it, incorporate it into your clinical toolbox, and take advantage of resources that help people learn these skills, including resources that are provided by our center, MCMH. The other reason I like CBT and motivational interviewing, because they tend to focus on teaching specific skills. I got a list here of some of the common ones we like to teach teenagers to help them with their decision making so that they're better at delaying gratification, resisting impulses, dealing with peer pressures. And these 2 techniques in one's clinical setting, I think, can provide not only the process by which you can teach skills, but they also provide some of the specific content for skill building. Okay, number 4. Level of treatment should match the intensity of the problem, not too surprising a principle. So you can see in this graph here, I've got a triangle sideways, and I've got 3 bands in the middle, one that says primary prevention, one that says brief intervention, and one to the far right in red, intensive treatment. And below that you can see sort of the match of the level of a problem that's consistent with the type of response one takes. So primary prevention is more relevant for someone who doesn't have symptoms, in the hopes that you can prevent symptoms from emerging. But people who have mild, moderate symptoms, it's suggested that they need low-intensive therapy or brief-type therapy and interventions. But people that have very severe problems are going to need more intensive treatment. So that's very logical, matching kind of the severity of somebody's illness with the amount of intensity of the response. In the world of adolescent brief therapies, there are 3 of them that are listed in NREP. You may know about NREP, this system developed and maintained by SAMHSA. NREP stands for National Registry of Evidence-Based Programs and Practices. You can go to the website and see more about it. This is a website that provides both an identification of evidence-based programs as well as a description of them. And so we went to the website and looked at some of the examples of brief therapies for teenagers, and here's 3 common elements we found among them. They tend to be in the range of 1 to 4 sessions. They tend to use MI and CBT, and they also have the feature that you often see in MI, and that is where you negotiate goals. So you don't always impose prescribed goals on the teenager, but you negotiate them. Also common, at least for brief interventions that focus on drug abuse, is you see the use of decisional balance exercise, or the so-called pros and cons interview, where you ask the person about some of the advantages of their drug use, what's their functional value, as well as what the negatives are. This can be a valuable brief interview that can give you a lot of insights about the individual's drug use, and it can help you already set the stage for what kind of treatment goals you want to work on with a teenager. We found 3 evidence-based programs in NREP that are specifically for teenagers. Brief strategic family therapy, teen intervene, and then one that is a nice combo of the 2 approaches I like, CBT/MET 5. The 5 is there because it's a 5 total session program. And they all have these common features I mentioned, but they all vary a little bit. If you go in and do some reading on them, you'll see how they vary. Obviously, the first one has more focus on family therapy. the other two less so. All right, then let me go further to the right in the red flag zone, where we want to consider people with clinical level problems, and those teenagers are going to get more intensive treatment. So if you survey common treatment approaches that are of the intensive type, I think you can see some core ingredients. And I've got a sample of things up here where there's a lot of attention toward building skills, convincing the teenager to make some lifestyle changes, including thinking about how they have fun and thinking about whether the friends they have are a good or bad influence. Most drug treatment programs, as already noted, have step work. Of course, important to deal with the specific mental health needs, including the family, and including a continuing care component. More on continuing care in a moment. And then for delivery purposes, you see the gamut: individual counseling, group, family therapy, and sometimes they're delivered in the home. I think that's an interesting approach that's showing some interest out there in the field, surely in the literature, where the therapist travels to the natural environment and conducts the therapy in the home. Continuing care is getting a lot of attention, and it makes sense because one should not think that treatment is going to be sufficient if we just think about the amount of time somebody gets their primary treatment. For many individuals, the behavior change process is going to be an extended enterprise, and the youngster is going to need help along the way. And so continuing care takes a lot of different approaches based on philosophy of the program, resources available, etc. I'm encouraged by the literature that is suggesting even brief booster checkups. There might be 10-minute or 15-minute phone calls periodically, maybe once a week. Maybe you start out twice a week and then you titrate down to once a month, once every 2 months, etc. But very brief and efficient. That can boost effectiveness. That can improve outcome. We found several evidence-based intensive programs listed in NREP. So all of these focus on adolescent problems, and all of them are manualized. And you can see there's a range here, but I'd make a case that most of them have nearly all or all of those core components I showed earlier. Okay, down to our last two habits. The fifth one is the importance of using developmentally appropriate, scientifically sound screening and assessment tools. For those that want to do some more homework on what are good tools fit this category, there's another tips that helps. Tips number 31. This just focuses on screening and assessment, so that's a free document you could download. And a recent one that helps with assessment challenges across the spectrum of youth disorders, child and adolescent, is the fourth edition of the excellent book, Assessment of Childhood Disorders. I'm just going to show you a couple that I like that are in the brief category. This is one that's called HEADS, H-E-A-D-S-S. It's been around a while and had various iterations. I like it because it provides a way to structure an interview briefly across a lot of different dimensions of one's life and teenage life. So H stands for getting a read on the teenager's home and their environment. Who do they live with? What's it like living at home? How many sibs, or what type of sibs do you have, etc. So both parents are living at home, or no? You have parents that are divorced, so how much time do you spend with one versus the other? Education and employment. What's it like at school? What are your grades like, etc. Activities is the A. How do you spend your free time? D for drugs. What do you use? Do you use frequently? Are you already showing problems, etc.? And then the two S's, important for the teenage life. Sexuality, not just their sexual activity, but also their sexual preferences, and the important suicide or depression one, HEADSS. So this can be developed into a brief interview where you just make sure you get information from the teenager across these important domains. For those interested in a brief screen for just the drug abuse category, there's a very good 6-item screen out there called the CRAFT. So I have here all the 6 items, and each letter of CRAFT stands for a key word in the item. CRAFFT. So you could turn this into an interview. You could put it as a self-administered test. 2 or more endorsements. So if you get yes or trues on 2 or more, that is suggestive that the teenager has a clinically level drug problem, and suggests the teenager then should get a more intensive evaluation and possibly need intervention. There are a lot of ways to enhance self-report when discussing clinical problems with a teenager. I have a list up here. I'm not going to go through all of them, but I want to re-emphasize that if you're good at motivational interviewing, you are probably also promoting a lot of characteristics in your interaction with a teenager that will advance good, valid self-report. Because you're probably then going to be encouraging rapport, you're going to be building confidence in the teenager, you're going to perhaps informally or formally establish confidentiality with him or her, etc. Also, sometimes you need to repeat testing if you don't feel like you're getting a good read on a given problem at a given point in time. Always keep in mind that you might want to wait a little bit and retest. And the last of my topics, last of the habits of highly effective counselors, is the importance of engaging parents in the treatment process. So many of the treatment literatures for specific adolescent problems do show that treatment approaches that include the parent to some degree tend to do better than treatment approaches that do not. And so what are typically done? What are the goals typically when we include parents in our treatment of for teenagers? I've got 3 to highlight. An important one, of course not a news bulletin, assessing and perhaps improving family interaction patterns, seeing if parents are good at communicating and making sure they're good at solving conflicts, and doing as best as they can as creating positive interactions in the home. We do this by, and I think a lot of counselors are doing it, whether they know it or not, by really teaching parents motivational interviewing skills, because it's a great way to deal with conflicts, to help take the emotionality out of difficult situations and interactions. It helps people so-called fight fairly, we call it, and many of the core motivational interviewing skills are things that can be easily learned by parents. Another category, number 2, is to assess and upgrade the 2 main parenting types of styles or practices. One is the supportive type skills, where you're emotionally close to the teenager, good listener, you're there for the youngster, and then the monitoring or the disciplining ones, where you're strong with setting rules, keeping on top of the teenager's lifestyle, how they're spending their free time, etc. The idea is to get a parent to be strong at both of these things. Parents that are either not strong on both or they're weak on both, these are less desirable parenting practices. So the notion is that you're not only close with the parent, the student and the teenager, but you're also very, very good at on top of the disciplining challenges. You're monitoring things, and you set rules, and if rules are violated, there are consequences that you follow through with. And the third one in this category is also talking with parents and getting them to make sure that their behavior, whether it's the behavior that is observed by the teenager or whether it's their attitudes and the things they express in the home, are a good role model for healthy lifestyles. Healthy in terms of a relationship with chemicals, healthy in terms of how you treat other people, how you spend your free time, how you exert your values. one of the things we do with parents in our program is walk them through this slide. P-A-R-E-N-T. Each letter stands for a principle that we think helps improve support behaviors, helps improve monitoring, and it helps get the parent to better understand the developmental characteristics, particularly brain maturation in their teenager. Understanding those, I think, can strengthen parenting. So P is to promote activities that capitalize on the strengths of the developing brain. Making sure the teenager has many opportunities for recreation, for fun. Making sure that their emotionality and motivational levels are and their needs are getting met at an appropriate, of course, level. A, assist your child with challenges that require planning. You got to help the teenager because they're not always so good with multitasking. R, reinforce their seeking advice from you and other adults. The notion here is the parent has a so-called mature prefrontal cortex. They're supposed to be pretty good at decision making, and the parent has to help the teenager with those skills. Educate the teenager about the risk, taking too many risks that have negative consequences. There's good risk and there's bad and unhealthy risk, and helping the teenager understand that. The N stands for never underestimate the effects that drugs have on the developing brain. Developing brain can be vulnerable to early effects, both on learning, memory, IQ, emotional development, and we want to get parents to appreciate that principle. And then T, learning to tolerate oops behaviors that can be common during the teen years. Oops behaviors are perhaps these emotional situations where the emotionality perhaps gets out of hand. Parents need to remember these things happen. They tend to abate and not to take them too seriously. Sometimes parents have to have memory lapses when teenagers are acting out. Okay, to summarize. I gave a review of 6 principles. I'm going to summarize them really down to 3 things to take home. One is the importance of understanding teenagers at multiple levels, not only from terms of brain development, but in terms of the mental and behavioral disorders that are common during this age time, this age period. I emphasize the importance of using assessments so you can determine the level and type of treatment. And I also am hoping you take away the importance of, if you don't incorporate an evidence-based program as a whole, hopefully you can incorporate some of those typical principles that are part of evidence-based programs, and you can work them into your clinical practice. Make them part of your clinical toolbox. So thank you for your time today.